vaccine implementation in Sierra Leone.
Yes.
That's fun. Okay, ICAP grand rounds.
Yes. Perfect.
Okay, that's fine.
Good morning, good afternoon, good evening, everyone. We're just waiting for everyone to join. We have our two speakers here, and we'll get started in just a moment. Thank you all for joining. We're just waiting for a few more. A lot of people are signing in. Okay, it's 9:05. I think we'll get started. Again, good morning, good afternoon, good evening, everyone. Thank you for being here for our next webinar. We have a very interesting webinar on malaria vaccine implementation in Sierra Leone. Malaria is the leading cause of morbidity and mortality in Sierra Leone. Specifically, the disease accounts for 37.6% of hospitalizations, which is a tremendous disease burden. In addition to existing national malaria control efforts, including dissemination of insecticide-treated bed nets, intermittent preventive treatment for infants and pregnant women, and indoor residual spraying, the government of Sierra Leone is introducing malaria vaccines for children under 2 years old in April of 2024. And Dr. Mam, our country director, and myself had the privilege of being at the airport in Freetown when the malaria vaccines were introduced, and we're eager to learn more about what has been done since December when they arrived in country. We have experts from the Ministry of Health and Sanitation and UNICEF in Sierra Leone joining us today. They will discuss strategies and experiences and lessons learned on the journey to malaria vaccine implementation. I'll introduce both of them and then we'll proceed. Dr. Desmond Mata Kangbai is the program manager of the EPI, or Expanded Program on Immunization, at the Ministry of Health and Sanitation in Sierra Leone. Dr. Desmond is a medical doctor and field epidemiologist working for the ministry. He is the program manager for EPI. As the head of immunization services, Dr. Kangbai is responsible for overseeing the country's vaccination programs and ensuring they are accessible to all Sierra Leoneans. He specifically leads a pilot approach to vaccination that seeks to assess and address an entire household's vaccination needs at once. In addition to his role for the Ministry of Health, he's an associate lecturer at Njala University College. He aims to guide policy making that would improve vaccine uptake within Sierra Leone and other low and middle income countries. And it's great to hear about your approach, Dr. Kangbai. We also like to have a family-centered approach, believe this is the best way of delivering care and providing a one-stop shop for services. Next is Dr. Babukar Boy, who's an immunization specialist at UNICEF. For over a decade, he has worked as a senior program officer at the National Immunization Program at the Ministry of Health in the Gambia. In addition, he worked as a consultant for WHO in Liberia, where he spearheaded the development and implementation of a national immunization plan. He has now worked with various UNICEF immunization programs since 2015. He provides guidance to the overall planning, implementation, monitoring, and evaluation of the National Immunization Program through collaboration with in-country partners. And today we'll learn more about UNICEF's role as a key partner in this program. So welcome, Dr. Desmond and Dr. Babukar. We really appreciate you taking the time to be here, and thank you all from across our countries for joining. Please go ahead. Over to you.
Hello, and good afternoon to each and everyone. Thank you so much for the introduction, and it's a pleasure to be here. As said, I'm Dr. Desmond. Over to you, Babuka.
Good morning, good afternoon, good evening, wherever you are. And thank you so much, Dr. Desmond. And my name is Babukar Boy, as earlier introduced. I'm the immunization specialist for UNICEF country office in Sierra Leone, and I'm based in Freetown. I am happy to be part of this session. Thank you.
Please proceed.
So much. As said, this is something we are doing in collaboration with our partners. I will be presenting on behalf of the Ministry of Health, and also Babuka will be joining me as a strong partner, UNICEF, for us to present this. So Sierra Leone, of course, we know we are going to give an update on the malaria vaccine rollout. So Sierra Leone is, of course, located in West Africa, and the west coast of West Africa. And of course, the population is approximately 8 million. An infant mortality of 78.3 deaths per 1,000 live births, and an under 5 mortality of 104.7 deaths per 1,000 live births. Next slide. And this is really very important. That's why as a country, we are placing an huge importance on the malaria vaccine, and we do consider the malaria vaccine as a game changer in reducing our infant and under 5 mortality. So malaria remains the leading cause of morbidity and mortality in Sierra Leone. And based on our malaria indicator survey, our demographic and health surveys that have been done in the country over the past year, the prevalence of malaria is almost 2 times higher in rural areas than in urban areas, account for 20% of children under 5 mortalities, 40.3% of outpatient attendance for all ages. So malaria is actually a very big deal and an issue in Sierra Leone, accounting for 40.3% of outpatient attendance for all ages, and of course 37.6% of hospitalized cases for all ages. Over the past years, with the implementation of comprehensive disease control measures, case incidence due to malaria has gradually reduced. So based on our interventions, there have been a reduction in malaria burden in Sierra Leone. Next slide. So this is the National Malaria Control Strategy. Of course, as we said, a lot has been done in the fight against malaria, as it's a very big issue and in Sierra Leone. So the vision is to accelerate the implementation of malaria control intervention towards a malaria-free Sierra Leone, and by the end of 2025, to contribute significantly to the improvement of the well-being of the population by reducing the malaria burden. So that's the vision and the goal of our national malaria control strategies. And of course, as we are looking at the goal, and these are the integrated vector management, of course, the use of the ITN distribution. We are doing mass campaigns. Recently, in January 2024, we distributed over 5 million bed net across the country. We are doing the IRIS, of course, we are doing promoting diagnosis. Malaria treatment in Sierra Leone is free. The government of Sierra Leone do procure malaria drugs, and of course, the diagnostic, the rapid tests are being done across the country. And as a form of prevention, we are also providing preventive treatments to pregnant women and children under 5 at PHUs, at peripheral health units. These interventions are really done in line with the goal, the vision and goal of the National Malaria Control Program. Next slide, please. So, of course, I will now focus on the malaria vaccines. With all said from the background, the burden of the malaria in Sierra Leone, the mortality, the most vulnerable group are the under 5 children, and Sierra Leone started the roadmap to apply for the malaria vaccine. So in 2022, when we received the notification from the WHO that yes, Sierra Leone could express an interest towards the rollout of the malaria vaccine, the first thing we said was, yes, the country would like to apply for the malaria vaccines. And we started the application process. We went through the processes. The application was submitted to Gavi. Our application stood out to be one of the best applications among all those that were submitted. It was approved. The Pharmacy Board of Sierra Leone also looked at it. They approved our application. The NITAG, the National Immunization Technical Advisory Group Sierra Leone, also gave their recommendation. So the vaccines were approved and doses were allocated to Sierra Leone. In December 2023, we received the first doses of the malaria vaccines in country. Of course, development of community strategies, readiness assessments were done. We did the micro-planning, of course, formation of district technical working group. This were done from the application period, because we needed to have a technical working group that will actually look at the application holistically and then develop the application. We did the micro-planning. In February 2024, development and validation of training material. And now we are at a point wherein we have done the demonstration of the malaria vaccines. And as we speak now, we started the rollout of the malaria vaccine on Monday, the 15th of April. And we have 16 districts, but we are currently rolling out the vaccine in 15 districts across the country, in all health facilities across the country in the 15 districts. The rollout of the malaria vaccine is ongoing now as we speak. Next slide. So early lessons and experiences from the malaria vaccines. So these are just the early lessons, because at the end of the day, we'll be doing the post-introduction and evaluation for the malaria vaccines, where we'll actually learn better. And of course, so doing the rollout of the vaccines, we have to look at prioritization of moderate to high transmission areas, because Gavi was actually looking at districts or communities with moderate to high transmission. So based on that, we looked at two indicators: the all-cause under 5 mortality from the demographic and health survey, and also all districts except Western area urban were considered as high. And also we are considered high with the exception of the Western area urban. And then we use the Plasmodium falciparum parasite rate, the malaria indicator survey 2021. 13 districts have a prevalence rate of 20 to 30%. 2 districts, Bombali and Western area, had a prevalence rate of 10 to 20, and Western area had a prevalence of less than 10. So 13 districts were classified as high, and 2 districts were classified as moderate, and 1 was low. So clearly we agreed to roll out the malaria vaccine since the focus was on the moderate and high transmission. So based on the criteria, we decided to roll out the vaccines in 15 districts, the moderate and high districts, with the exception of Western area that was left out. So now the vaccine rollout is ongoing in those 15 districts that have been classified as high and moderate transmission areas. Next slide. So this is just talking about the creation of the malaria vaccine TWGs at the national level and district level, because there was a need to bring on board different stakeholders. You know, when we talk about malaria vaccine, when we talk about vaccination, it has to be community driven. It has to be ownership of the community. The community will have to take decision on how the vaccine should be rolled out and what's going to be the role of the community, and of course, commitment from the community, because we have learned from the Ebola outbreak, from the COVID-19, that when the community, when the stakeholders at different levels are being involved in immunization or rollout of health services, we get a huge success. So this doesn't change for the malaria. So there were at the national level meetings we are held weekly, and of course at the district level meetings we are also held, bringing on board all stakeholders, a lot of community engagement, sensitization on the malaria vaccines. Next slide, please. So of course, this is just talking about the robust electronic case-based data monitoring system using DHIS2 to fast-track vaccines. So what we did with the malaria vaccine, we are leveraging on experience from other implementation. For example, with the COVID-19 vaccination, we developed a case register. So what is happening in Sierra Leone in general, we have an electronic reporting system, but it's the aggregate reporting system for all antigens, which is being done at the end of the month. But what we want to do in this case for the COVID, what we want to do in this case for the malaria vaccine as the COVID, is to have a digitalized system, a register that will help us follow up on each and every child receiving the vaccine. We want to ensure that a child receiving the first dose will receive the second dose, the third dose, and the fourth dose in time, so that we'll be in place to even call the district and say, child A, B, C, D are due for their second dose, but they are yet to take their second dose. They are located in community A, B, and C. Kindly locate them and ensure they get their vaccines. So we engage the US CDC, our partners, and then we brought about the case base, which was used for COVID. So we are also using that case base for the malaria vaccine. And of course, we are also going to use the aggregate at the end of the month that will be set, just for us to ensure we integrate our services, and lessons learned from the malaria vaccine will be used to see if we could actually cascade to a case base for all antigen across. So these are just pictures of how the system will operate. Next slide, please. So of course, this is a vaccination target set at subnational level population. So, and our plan during the first year, 95% of so of course we use the surviving infant population to actually calculate and the number of children who will be reaching. So for now, during the first year of vaccination, we plan to reach 95% of the target in 15 districts with at least with the 3 doses, because the first dose in Sierra Leone, we are giving our first dose of the vaccines at 6 months, second at 7, third at 8, and then the final dose at 18 months. So we want to ensure in the first year, we reach 95% of the targeted infants in the 15 district, which is approximately 95% of the 286. Next slide. So this is just discussing around effective public health communication tools for disseminating accurate information. So we develop banners, we develop posters, we develop fact sheets on the malaria vaccines. These fact sheets and banners we are sent to the district. They are shared with community stakeholders. Also, we have the CHWs, the community healthcare workers that we are trained, the peer supervisors. We shared with them so that they could use this one to actually update and community leaders. And if there are any comments or things that they want for clarification, those clarifications will be done, and they will have enough knowledge on the malaria vaccine. Most of the time in communities, what happens in communities is, and people have their perceptions about vaccines, and people have things they read on social media around vaccines. So we ensured to have messages out. We developed radio jingles in different languages in country, and we developed different messages across in different languages for them to be cascaded so that people could really listen to them. And we also engage stakeholders across the country on the malaria vaccines, the parliamentarians, the members of parliament, the paramount chief, the locals, the interreligious councils, the local leaders. They were all engaged. The women's group were brought on board because they are the ones that pioneer vaccination. And we brought also the male groups on board because we think vaccination is not only about women, but also and fathers should take their children to the health facilities for vaccination. So these are just examples of some of the messages that we are developing. Inclusive routine immunization coordination platform, improve planning and resource mobilization, engaging stakeholders through regular coordination meetings to foster dialogue amongst stakeholders, mobilize resources, and created synergies on malaria vaccine introduction. So there are a lot of engagement done at different levels. And one is the interagency coordination committee technical meeting chaired by the Honorable Minister of Health and co-chaired by the Minister of Finance. So these are platforms that we use to engage them, sensitize them, and also get resources for them towards the malaria vaccine. Of course, we have the technical coordination committees chaired by the EPI program manager, brought together technical agencies and MOH technical staff to develop overarching implementation plans, monitor their implementation, and identify. So the TCC was formed, the interagency committees, we had the TWG, the technical working group with different subunits. So there were a lot of engagement just to bring people on board, because in Sierra Leone, our lessons, what we have learned is we bring more people on board in this planning. Our partners international, the global partners, and even our local partners. And we all do the planning so that each and everyone will buy in. And also it will serve as a platform to get more resources in terms of sensitization, more resources in terms of using different fora to actually get to people across. Next slide. So these are just examples: effective community engagement. Community healthcare workers will engage the CHWs, will engage the peer supervisors of the CHWs. At the national level also, we did engagement with paramount chiefs. Paramount chiefs are traditional leaders in their communities. People listen to them very much. We engage the interreligious councils. So these are just pictures of engagement that were done at different levels. Next, please. So this is also looking at fostering relationship through electronic media platform to promote rapid dissemination of information on malaria vaccine within and outside program. So there were a lot of platforms that were also used to help us actually disseminate messages of malaria. So, and of course, this page is looking at the light of hope. Mama Jallo received the first WHO approved malaria vaccine. So as part of our sensitization, we also shared pictures like this, where you could see Mama Jallo, and at 6 months was the first child to have received the vaccine, the Sierra Leone vaccine that was in the demonstration that was done on Friday, the 12th of April. And then all those different platforms were used, social media platform, to actually sensitize people so that the message could get to people that, yes, people are bringing their children for vaccines, and we expect each and everyone to do similar. Next slide. So, of course, this is also talking of the timely adaptation of existing guidelines, protocols, and tools has led to effective and efficient integration of malaria vaccines into routine immunization. So we didn't use, and because the malaria vaccine is an integration into the routine immunizations, so we had to also look at in-country and document policies, strategies, and we use those strategies to actually and reach more and actually bring on board the malaria vaccine. So of course, we looked at the EPI policy, the missed opportunity for vaccination, and the catch-up policy. These were all reviewed so as to get, because we don't want to reach those stages at the health facilities where the heads in charges or the vaccinators don't have clear insight on some of these policies. So they were updated, disseminated, and people were trained and sensitized on them. For example, missed opportunity for vaccination and catch-up policy guides the implementation of approaches for mixed vaccination and other child health intervention, monitoring and evaluation. Those were all reviewed and updated. Next slide. Of course, leveraging existing information on the vaccine supply chain to boost the country capacity to meet additional cold chain requirements. So of course, we look at our cold chain requirements, we look at the cold chain space available, we leverage on the EVMA, the effective vaccine management assessment, and the coastal assessment that we did. And of course, we did repair of our cold chain equipment to ensure we have adequate space and we have the required capacity to store these vaccines across the country in all our facilities offering immunization services. So we did repair of non-functional refrigerators and substitution of low for high volume refrigerators, because also recently we have added more antigens, the HPV vaccines, the malaria now coming in, the COVID vaccines, more antigens have been added, and of course there have been increase in population and demand. So, and we also had to look at the capacity, the volumes across the country. Next slide. Workforce development, of course, this is very important. And also, as we said, malaria vaccine is a new vaccine. We are integrating into our routine system, and we are going to use the malaria vaccine to strengthen all routine immunization in country. So that's why even our 4th dose at 18 months is a strategy to catch up on children that will miss the 2nd dose of the MR vaccines at 15 months. So those that will miss the MR2 at 15 months will be catch up at 18 months. So those are all strategies we looked at and how we could develop the malaria vaccine and also strengthening. So work development, develop malaria vaccine introduction curriculum and supportive supervision based on WHO guidance, vaccine efficacy and safety data from manufacturer and pilot countries. And of course, 1,500 teams trained in vaccine administration and handling, they were trained, and 64 national supervisors are currently deployed in each of the 15. So we trained the healthcare workers very well on the malaria vaccines, how it's being administered, the safeties of the malaria vaccine. We also focused on the adverse event following immunization. That we are trained, the CHWs we are trained so that they could report. So an integrated and well-structured training was done across the country for healthcare workers. And of course, the national supervisors were also trained and sent to the district to actually support this training at the district level, provide mentorship, monitoring at the district level. Next slide. Of course, this is part of our continuous assessment. So throughout the malaria vaccine, we did a lot of readiness assessment to see if we are really ready to introduce the malaria vaccine. What were the challenges? What were issues that to be addressed to ensure we get a successful malaria vaccine introduction? So the readiness assessment was done on four occasions or several occasions as stated here. We did at 1 month, at 2 weeks, at 1 week, and then at 3 weeks to the introduction. And we could see the progress in as we move towards the introduction. You could see the coverages, and as we made the percentages as we move towards the introduction as highlighted. And so so at 3 weeks to the introduction, and we are actually at 70%, at 90% at 3 weeks, at 3 days to the introduction. Those issues that were not addressed were looked into, and they were even addressed as we went very close to the malaria introduction. And the issue here that made us to be at 90% is the monitoring. The monitoring do occur during the introduction of the malaria vaccine. So it was done 3 days before, as by assessment, it was done 3 days before before the introduction. So that's why the monitorings are being done at different stages. And there is one particular monitoring that happens within the introduction. So that's why we are a bit low on the monitoring. As I said in the previous slide, 64 of our supervisors national are now on the district doing the monitoring as the vaccination, because the role is, as they are doing the vaccination, you support the district as a national monitor or supervisor and in getting the daily meetings, daily updates, challenges coming up from the field. Those challenges are being addressed or escalated to the national level. So the monitoring is going on now. And of course, advocacy, social mobilization, and communication. There are also aspects of advocacy, social mobilization, and coordination that will go on during the rollout. So that's why some of those, but if you look at vaccine coaching and logistics, we are at 100%. And you look at AFI surveillance, and if you look at training, all those have been completed. So that's why we are at 100% in 3 of the lines, because some do happen. But in general, and 3 days before the rollout, we're at 90% readiness. Next slide. Of course, these are just talking of the different intervention. Trust in the community, in the country's leadership, and the information they provide has been essential in addressing. So the first picture up is just showing the leadership engagement with the Honorable Deputy Minister of Health, and I think the female in the middle, Dr. Jalikatu Mustafa, and of course the malaria vaccine introduction talking points developed for the leadership and even for His Excellency the President. And then down we could see the first child receiving the first dose of the malaria vaccine in country. You could see the media coverage and the child, and it's sending a good message out that here in Sierra Leone, vaccines are being accepted by each and every one and in Sierra Leone. And of course, these are just giving point on a national launch will happen. The official launch of the malaria vaccines will take place on the 25th of April next week, and this will be done by His Excellency the President. This is to further and sensitize people and to further inform people on the malaria vaccine and to further align with the leadership of the government in supporting the role of the malaria vaccines. Next slide. So of course, this is the malaria vaccine for malaria vaccine visit, an opportunity to increase coverage of other vaccines and to provide other childhood health intervention. So as I said before, this is the 4th dose of 4 doses of the malaria vaccine, 6, 7, 8, and 18 months. And of course, doing these processes also, we'll be doing every monthly, and we'll be doing growth monitoring on a monthly basis. So anytime this child comes in, there's also an opportunity to do growth monitoring and also detect if abnormal growth of the child during this 4 months, which is we'll also be doing deworming of the child. We'll also be giving vitamin A, and it will also serve as an opportunity to catch up on all other antigens. And even the parents coming in, if they don't have the HPV vaccine, they don't have the tetanus, diphtheria vaccine, or they haven't taken the HPV vaccine or COVID-19 vaccines, it will also be an opportunity to provide additional vaccine and information to the caregivers. Next slide, please. Challenges and solutions during the pre-implementation phase. As I said, the child will be looking at more challenges. We will learn more in the post-evaluation survey. We'll be doing the PI, the post-implementation evaluation. We'll be doing the PI. In the PI, we will learn more. We'll look at more of the challenges. And every day, as we are rolling out the vaccine currently, the supervisors are sending out and also what are the challenges. But so far, these are the major challenges: suboptimal fund for some of the critical components of the introduction process. Government of Australia in collaboration with health development partners through the ICC mobilized additional funds for some of the prioritized underfund activities. And of course, that's why we have all those coordination forums to ensure we get additional resources, integrating activities with other funding activities, for example, micro-planning and vaccine distribution and reverse logistics. So based on in-country available funds or other routine structures, we also use other routine structures like vaccine distribution, micro-planning to actually support the malaria vaccine rollout, and of course, emerging public health challenges, including the circulating vaccine-derived polio virus too. So this is also a challenge, as we are rolling out the vaccines, we are rolling out new vaccines. What happened there? Also emerging or re-emerging and outbreaks of conditions happening. Like now, we are talking of the CDPV2 outbreak in Sierra Leone. So we'll also be doing 2 rounds of immunization. And of course, there's the malaria vaccine introduction work plan. And of course, the measles rubella campaign. So we are integrating, and those are some of the challenges that do deviate or impede our successful rollout of some of these interventions, because they are new things or they are other things that are re-emerging and they do affect us. Next slide. So on this case, I think, and looking forward is also we want to see study case based to do a study case based malaria vaccination data to document progress, vaccine safety. We have already developed protocols so that we could follow up on the children receiving the vaccines and how we could evaluate. Enhanced learning through post-introduction evaluation, of course, that is very important. We'll also be doing the post-introduction evaluation. Next slide. So partner support for immunization. Next slide.
Thank you. That's mine.
Go ahead, Babukar.
Thank you so much, Dr. Desmond, for that beautiful presentation. And colleagues, as you have heard from Dr. Desmond, you've come to realize that Sierra Leone has a wealth of experience and technical capacities to develop, to introduce vaccine into routine EPI services. And again, as we always say, behind every strong EPI program, there must be a good and committed health development partners. And in Sierra Leone, we have several immunization stakeholders that are supporting the national EPI program to ensure that the program is able to deliver effective, equitable, and sustainable immunization services to all children, irrespective of who they are and where they live. So before getting into my presentation proper, I want to join Dr. Desmond to emphasize the importance of the rollout of the malaria vaccine, which marks a significant milestone in the fight against malaria. And of course, we all know malaria is a life-threatening disease that has already killed thousands of young children and is putting, thousands of your children's life at risk, especially in our African region. So as indicated by Dr. Desmond, the receipt of the first malaria vaccine shipment of about 550,000 doses, of course, is a clear testament to the unwavering commitment of our global partners and dedicated efforts of our government in prioritizing the health and well-being of the children. Lastly, as we all know, UNICEF has been the largest buyer of vaccines globally. And this, of course, would be used to ensure that the malaria vaccine is available as and when needed. So, as I said earlier on, there are technical partners in Sierra Leone that continues to support the EPI program to be able to deliver immunization services wherever it is needed, especially to children, including those hard to reach areas. And key among the supports we continue to provide to the Ministry of Health includes building credible partnership, that is collaboration with health development partners. Of course, this has been key in ensuring the availability of vaccines within the country. As you have seen in these beautiful pictures, this is at the airport, Lungi International Airport, and almost all the immunization partners were present to receive the first shipment of malaria vaccine and hand it over to the government of Sierra Leone through the Ministry of Health. Next slide. Again, continuing on the building the credible partnership, ensuring optimal cold chain system is available at all levels, both at central, district, and also at health facility level. And UNICEF continues to support the government of Sierra Leone, including other immunization partners, to procure, transport, and install cold chain equipment, especially at service delivery level. From 2021 to date, using the COVID funds, we were able to procure, transport, and install over 800 sets in our health facilities, and this has really helped to expand and modernize the cold chain system at health facility level. And as we speak, over 90% of our health facilities in Sierra Leone have functional cold chain system at facility level, and this is critically important to ensure that vaccines are of good quality. And again, the health facility staff are able to deliver the services needed, especially at health facility and also at outreach services. So this is a sample of the handing over, and you can see the UNICEF rep and other development partners handing over the equipment to the Honorable Minister of Health. The second picture also shows our beautiful central API vaccine stores in Freetown, where UNICEF using funds from Gavi and other partners, and in collaboration with other immunization stakeholders in Sierra Leone, we're able to procure and install beautiful cold rooms, which are 5 in number, in Freetown at the central API vaccine store, to be able to store all the vaccines that are received from out of the country, and awaiting further distribution to all the 16 district stores. And of course, these are the same equipment that are used to store our malaria vaccines. Next, please. Again, as I mentioned, several support have been provided to the Ministry of Health, and this also includes the procurement and delivery of motorbikes. Over the past 2 years, UNICEF, together with other immunization partners, we were able to procure and hand over 900 motorbikes. And these motorbikes are critically important to improve on immunization service delivery, and they are being used to conduct supportive supervision at lower levels, and also to conduct outreach immunization services, including other primary healthcare services, and also to support last mile supply delivery, to collect vaccines and other supplies from our district stores to the health facilities. And again, these bikes are used to deliver immunization services, as you have seen in the picture. And again, in addition to the motorbikes, we were able to procure refrigerated van. You can see UNICEF is handing it over to the Deputy Minister 2 of the Ministry of Health. And this refrigerated van is being used to transport vaccines to districts that cannot be reached by our bigger refrigerated trucks. In country, we have bigger refrigerated trucks that deliver supplies to district vaccine stores. But in addition, this smaller van has been procured to go to, cut away district stores that cannot be reached by the bigger one. Of course, the EPI program cannot go without mobility. Vehicles have also been procured and delivered to enhance national program management capacity, as you have seen in the pictures. Next, please. Yes, so finally, before I end my presentation, UNICEF together with other partners, as you have seen in this slide, we continue to provide technical support and guidance to the API program, especially in the areas of proposal development for new vaccines. And once these proposals are accepted, like the malaria vaccine, we supported the API program, as has been mentioned by Dr. Desmond, to ensure that all the pre-introductory activities are implemented fully to ensure that the vaccines are rolled out effectively. And such pre-introduction activities include micro-planning sessions at all levels, especially at district and health facility level, to determine and quantify needs to ensure that these are provided before the actual introduction of the vaccine. Another critical area also is capacity building, as you have seen in this slide, training of health staff on effective vaccine management and cold chain management practices have also been conducted, in addition to the readiness assessment that have already been highlighted by Dr. Desmond. Infrastructural development is also another important area that partners continue to support. Currently, UNICEF is providing support to the construction of district stores. We are currently constructing about 5 district stores, and constructions are also ongoing. This will also help us to expand and modernize the district vaccine stores so that they are able to accommodate adequate cold chain equipment and other supplies for vaccines to be stored adequately so that they are of good quality. Solarization also, we have started solarizing the health facilities because staff retention is critically important to be able to improve on the immunization performance. So solarization also has been a critical and focused area that UNICEF and other partners have been supporting to the immunization program. Finally, community sensitization and engagement has also been a very critical area that we continue to provide support on, especially for routine and also for other emergencies, so that this will help us to increase uptake of services. And I think you will all be able to witness that Sierra Leone immunization program has been doing very well, as has been mentioned by Dr. Desmond. Our coverages are above 90%, and community sensitization and engagement has been critically important towards that. And as I indicated in my first slide, we have several immunization partners, including Gavi, CDC, ICAP, UNICEF, WHO, AFINED, Focus 1000, Africa CDC. So we have several immunization partners who are really committed to providing the technical support and guidance needed. And these are always provided as and when requested by the API program. So thank you so much. And that's it.
Wonderful, wonderful. Thank you, Dr. Desmond and Babukar. We really appreciate it. Perfect timing. We have just under 15 minutes for Q&A. To everyone online, please feel free to type your questions into the chat box. We've received a couple that I'll go through now. Just a reminder as well, we have AI transcription services. If you click on the link in the chat box, it'll give you a transcription that can be translated into other languages, and we're still working on getting real-time transcription translation, but I hope that the English transcription will be helpful for those who are Francophone or Lusophone. So I really appreciated when you said that malaria vaccine is a game changer, and just looking at the burden of disease and the infant and child mortality rate, Sierra Leone is right at the top of concern. So this, I hope in the next couple of years, we will see a precipitous drop in mortality rate. I was looking at some of the statistics, and the mortality rate has been dropping over the last 4 or 5 years, but is still quite high. And as you said, Dr. Desmond, the rural areas, the burden is 2 times higher. So the first question I have is what has been the biggest lesson learned as you've rolled out the malaria vaccine? And secondly, has there been any challenge with misinformation or myths arising around or hesitance to take up the malaria vaccine. I believe you alluded to the fact that the uptake, the interest is very high, but just wondering if that has been a challenge.
Hello, do you want us to respond now?
Yes, please. Yes.
Thank you so much for the questions. These are really very interesting and factual. And the biggest lessons learned, and Sierra Leone, we have been doing immunization. I think since the 1964 or 1970s, we have been doing immunization. And as the name goes, expanded program immunization, we have been expanding on immunization services. And looking at that and what has been the biggest lessons learned, we have learned a lot, not only from the malaria vaccine, but in terms of vaccine delivery. And looking at the burden of malaria, we said malaria vaccine is a game changer, and this is an opportunity for us to reach more with the malaria vaccines. And during COVID-19, we did a study looking at solving last mile delivery challenges is critical to increase COVID-19 vaccination, solving last mile challenges. So with the malaria vaccines, we have already looked at it as a 4-dose vaccine. This is the first time we are giving any vaccine that is a 4-dose within Sierra Leone. We have been given the Penta, the TTP at 3-dose. So and that's why we brought on board the electronic reporting system. We have brought on board, we have prioritized looking at the communities, how we could integrate the vaccines into other routine immunization services, into other healthcare services. We're talking of the life course approach to vaccination, which is a top priority of the Ministry of Health. How could it be a life stage approach? We have integrated the malaria vaccine into all our policies, catch-up policies, and even the immunization policies. So one of the lessons learned so far is the community engagement component. When we involve the communities, we get better results. When we involve the communities, we reach more people. The people, when we involve the ones we call vaccination champions, that are origin from each of the towns within the country or villages, we get more people to take the vaccine. So I think that is a very good lesson that we have learned with our malaria vaccination. And in terms of misinformation, we did a perception survey before the actual rollout of the malaria vaccine, or even when we started developing our messages. And from the perception survey, the issues that were identified, the messaging was done to sort of mitigate some of those issues that were really identified. And Sierra Leone, and we have given COVID vaccines, and in the midst of COVID vaccines, we gave the Ebola vaccine. We integrated COVID vaccines and measles vaccine with a new vaccine that was the human papilloma virus vaccines. And the uptake was very high because of the strategies that we have been using. Yes, there will be misinformation, but we bring communities, as I said in one of the slides, we develop messages. Those messages we are shared with community stakeholders, with CHWs. They were encouraged to go to the communities, even door to door, and sensitize people. So in terms of misinformation, yes, it do exist, but we have mechanisms in place to actually respond to them, to keep update. We even have rumor logbooks at health facility level on vaccination. So some of those rumors coming up will be noted in the rumor logbook and then communicated with the district or with the appropriate authorities so that action could be taken. So those are some of the ways we are responding to some of the rumors, the misinformation. We keep sensitizing people. It's an ongoing community engagement and sensitization on vaccines. These are ongoing, and we keep doing them just to ensure we get the adequate coverage and involvement of each and everyone. Over to you, Chief Babuka. Do you have anything to add to that?
You've said it all. Last week we were in Cameroon, and we during those interactions with other countries, we've learned that the malaria vaccine has faced a lot of resistance in those countries. But as you rightly stated, the communities in Sierra Leone are very receptive to immunization services. Once you are able to reach them, they are readily available to receive these vaccinations. And as you have mentioned, at the peak of Ebola, there were no major resistance to immunization services, all because we were able to, develop communication messages and strategies in partnership with the communities to get in their buy-in so that they will readily come out and accept the vaccination services being delivered. Thank you so much. And I think this is one of the greatest opportunity and strength for the National EPI program in Sierra Leone. Thank you.
Yeah, it's a word for every country. You've really built on the last 60 years of experience beginning in the 60s. And I think all of your experience from tackling the West Africa Ebola crisis, it really is amazing what you've been able to achieve, bringing on so many different vaccinations, including HPV vaccine. And it sounds like you've really preempted any myths or misinformation from taking root by that active community engagement. Another question has come in on this topic, and then one additional question. I'll give you both questions now. So the first one, let me just go down. Community engagement. Are there formal or non-formal community structures that you have used apart from the vaccine champions? So that's one question, formal or informal structures beyond vaccine champions. And then the second question is cost. What have you learned about costing and any advice on reducing cost? Over to you.
All right, thank you so much. Of course, and we have formal means of communication wherein we bring the stakeholders together, we send them invite, they come, we engage them. And then we have those informal communication messages wherein our own head staff, they just go to the communities, to the market center, the religious places, and they just go to sometimes randomly go to school environment and sensitize people on the vaccine. Or sometimes they go to these marketplaces doing the market days with their megaphones, and they just reach out messages on vaccines or health service delivery to the people. Wherein they are also formal, when we have to engage schools, send them letters. We send key experts to schools doing their devotions to talk to children or to talk to girls about the HPV vaccine, the importance of the HPV vaccines. And also in our ANC antenatal clinics, we also make use of those antenatal clinics. We are in the healthcare worker in the morning. We have to talk to the parent or whosoever is coming for ANC. They are being educated on vaccine, on health service delivery. So there are a lot of engagement, both formal and informal, in terms of vaccination. In terms of reducing costs. So when we talk about reducing cost in terms of vaccination, we are not only referring to our own cost, but also the cost on the side of the caregiver. And just like I said, we did a study. We have been doing studies around vaccination. One way we have reduced cost in terms of implementation of vaccine is by doing integrating services. Because when we integrate services with one campaign or with one rollout, you could actually do 3 or 4 immunization intervention, looking at nutrition services and other services could all be done within the same period. By that, you are reducing cost. So that's why I said, and when we are rolling out the HPV vaccines, we didn't have enough resources, and we decided, okay, we are doing and campaigns for COVID-19 vaccine. Why can't we integrate this HPV into COVID? We also bring on board the measles and we deliver them to the community and we see what happened. And with that, the coverages were high, and then we had enough funds to actually do all. So integrating services actually help us to save resources. On the side of the caregiver, one of the major barriers to vaccination is distance, access to health facilities. Because we also know the socioeconomic and situation or status of our country and our people. So people living far away from health facilities find it difficult sometimes coming to health facilities to take vaccine because of the cost involved. So we also looked at the possibilities of conducting outreach to some of those hard to reach communities, those riverine communities. We're taking the commodities to them. And when we are taking the commodities to them, what happened? There's a high uptake of the vaccines. Things we thought were around hesitancy. They were not actually hesitancy. There were issues around cost in getting to the health facility. Maybe you have to pay let's say example, $5 to get to a health facility to take vaccines. And you have other priorities in terms of getting food and other things for the family. So most people don't come for the vaccine. But when we take it to their communities, we take it to those hard to reach areas that we are taking the vaccine. So we thought the issue is access, and is the issue is we getting to them. So we also reduce the cost on their own side in terms of taking the vaccine and other health services. And the way, vaccines are more like a primary healthcare, a preventive strategies. And sometimes in our community, you prefer to get food to eat for your child than taking your child for vaccine. That is not sick at all. That the child is not sick at all. You just need to follow the normal schedule. So those are some of the challenges, but that's why we are also investing a lot in outreach services, ensuring we take our services to the doorstep of the people. Over to you.
Thank you. Yeah, thank you. And incredible lessons learned and really best practices in how to deliver community-centered, really reducing missed opportunities, trying to provide as many services as at one time, and not expecting everyone to come to us, but going out to them. Really rich lessons learned here. So thank you both for your time and for sharing this very exciting experience. We hope to have you back again in a year and learn about the tremendous reduction in infant and under 5 mortality rate. Really doing great work. Now our time, we're at the top of the hour. I want to introduce that we'll have our next webinar on May 21st, and the focus will be on global mental health, and we hope all of you will join us. Thank you all for the questions. And again, thank you, Dr. Desmond and Babukar, for your time and for sharing your expertise. We sincerely appreciate it. Thank you all.
Thank you too.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you.